Hi, I'm Tari Turner, Director of the National Clinical Evidence Taskforce and an Associate Professor at Cochrane, Australia in the School of Public Health at Monash University. Welcome to Taskforce TV. I'm recording this today on the lands of the Bunurong people, and I pay my respects to elders past and present and acknowledge that these lands are unceded. In our final episode of the year, today we'll discuss the latest update to the Taskforce CPR guidance, and I'm delighted to be joined by two, well, let's admit it, of my favourite Taskforce members, Professor Peter Morley and Professor Simon Craig. Both of these gentlemen are members of the Taskforce Cardiac Arrest Working Group and contributors to multiple groups within the Taskforce. Peter's a Senior Intensive Care Specialist at Royal Melbourne, as well as Director of the ICU at Melbourne Private Hospital. He's Chair of the Australian Resuscitation Council and a representative on the Taskforce Steering Committee. Simon is a Paediatric Emergency Medicine Physician at Monash Medical Centre, an Adjunct Clinical Professor at Monash Health, and an inaugural member of the Paediatric and Adolescent Care Panel of the Taskforce. Thank you both very much for your time today. I want to start with what's perhaps a really basic question. Why are we talking about CPR today? How does this whole CPR thing connect to the Taskforce's work in COVID? Peter?
The Taskforce obviously deals with a whole pile of questions that relate to management and impact of COVID-19. And cardiac arrests are a major cause of death. In Australia and New Zealand, one person has a cardiac arrest outside of hospital every 17 minutes, and a similar number occur within the hospitals. And the rescuers can have a dramatic impact on the survival, but resuscitation requires close contact with patients. So there are concerns about disease transmission, predominantly around the patients to the rescuers. And the Taskforce has been able to bring together key professional organisations along with the Australian Resuscitation Council to consider ways in which we may need to alter our standard practice and convey a really simple, consistent message. So
I'm interested because you both have quite different clinical roles, and I imagine that things have changed around CPR over the course of the pandemic. I can't believe we're coming up to almost 3 years in this COVID space. Can you tell me a little bit, Simon, about how CPR has been impacted over the course of the pandemic and perhaps how things have changed?
Yeah, it was really interesting. Early on in the pandemic, there were concerns about aerosol generating procedures and what was an aerosol generating procedure and what wasn't an aerosol generating procedure, and no one really knew what to do. And CPR, you've got to do things quite quickly. And if you're not doing things quickly, people can die. And if you do things quickly and efficiently, then people can live. But at the same time, there was all this fear about, am I going to get sick myself? Is something bad going to happen? So the initial response was, oh, no one does anything until we're all fully dressed. But at the same time, we don't have enough equipment to be fully dressed all the time. And there was this big tension between people turning up really ill in the emergency department, but us not being prepared. And so in the first few months, we went from not really having a clear plan to developing a plan and developing the first set of guidelines. And we've gone now from a place where we weren't vaccinated, we weren't sure about PPE and all the other things, and the hospitals really weren't set up for people with COVID, and we didn't know who had COVID and who did, to now we've got enough PPE, we've got a highly vaccinated workforce, we've got a highly vaccinated population, and there's less COVID around, although there's still a bit, and we're identifying people with COVID a lot faster. So the environment's changed and the risks to health professionals have changed significantly during that time.
Peter, you work in a different clinical environment to Simon. How has your experience been the same or different from his in terms of how concerns and approaches to CPR have changed over time?
The way that Simon described that there was this sort of initial terror, not quite sure what's going on. There's a little bit of denial. And now I think now that people are vaccinated and they understand PPE, there's a lot more understanding, confidence in the process. It's more a can-do attitude rather than a, oh my God, I don't want to get involved attitude. And so I think that that's been really, really a dramatic change over the time. People are a little bit more comfortable, though there is still quite a variability in comfort with the whole thing. And certainly within the community, there's a variability in comfort as well.
And I want to come back and touch on the kind of different messaging for community members and clinicians too. You've both mentioned PPE and, the early, very significant concerns around protective equipment and infection prevention and control. Perhaps a slightly broader question, Simon, for you first. Are clinicians still concerned around these issues of infection prevention and control in hospital settings now? What's the approach to that?
I think the concerns have changed because early on, you were sort of asked to change your PPE depending on what you were going to be doing. and say, for example, if you're going to be managing a patient in a certain way, then you were dressed for that occasion. But then if they got worse, then you'd have to get changed and change your PPE and those things. And that's crazy. It doesn't, patients won't give you an opportunity to get changed if they're going to deteriorate. So it took a few months to get to the point, well, okay, if you're working in an emergency department, you're working in an intensive care unit where there's COVID patients around, you've just got to be dressed to be able to do everything all the time. And initially we weren't. So that was where that tension was. Now I turn up to work and I'm just wearing an N95 and I'm wearing eye protection or whatever else, because I don't know which of those children that I see are going to have COVID and which of them aren't, or which one's going to come in sick, and someone coughing in my face is probably a higher risk than needing CPR. So I might as well be dressed for every eventuality all the time. And that was a big change. But there was a few months of what is an aerosol generating procedure, what isn't an aerosol generating procedure, and that caused a huge amount of tension and a lot of debate because we just didn't know.
Seems like there was a lot of stuff we didn't know, and happily we've gathered some information, some evidence and some expertise over time. Peter, is the situation the same in your settings, the same kind of change?
Yeah, same sort of thing in intensive care, though we tend to be looking after a large number of people that we know don't have COVID. And so in that situation, we're happy to just have a minimal sort of protection. But as Simon pointed out, what we tend to do in hospitals is we actually all wear N95 masks when we're around patients. And usually there's a requirement for some sort of face protection as well. So in the presence of those two things, it makes it a lot easier. We still have a slight differentiation between the suspected COVID or the known COVIDs. Where in that situation people will dress up. We will usually use a gown, though that's a bit of an optional thing, and then we'll wear some gloves. So there is still a little bit of variability, but as Simon pointed out, it's really important for us to be anticipating, and there's no longer the, oh my God, we can't do anything because we're not dressed appropriately. We anticipate that and we dress appropriately.
I think the other thing there is that we had, from an emergency point of view, we weren't, these were all unknown patients when they were coming in. And, if someone comes in off the street and, there's skyrocketing COVID numbers and everything, you don't know whether they've got COVID or not, but you don't know that they don't have COVID. They don't know that you do have COVID. And so there was this tension. I think once they get to intensive care, they've often been tested. So you've got a little bit more comfort and security that they don't have COVID, or that they do have COVID. And therefore you can sort of prepare yourself. And so I think, having that certainty, but also just that certainty of you're protected, not only with your PPE, but also the vaccines work, they're sort of helpful thing to have in the armoury.
Completely agree. It's the key message on all of these Taskforce TV things is get vaccinated. This is now, we've updated the CPR guidance multiple times. In fact, in my brain, this is now associated with it's almost Christmas, because we do tend to update these heading into summer. Peter, could you give us an overview of kind of what the key changes are in this latest update to the guidance?
Sure. Well, the Christmas present to the community is the new guidelines. Look, I guess overall we're considering the healthcare setting now refers to care of people, not just adults. So it's children and adults, and I think that's really important. And also to the care of suspected or confirmed COVID rather than just confirmed COVID. So that's an important sort of broad descriptor. We've deleted the concept of the minimum requirements as we're talking about PPE requirements. We're really talking about what are the preferred PPE requirements for these settings. And that is the same. That's a standard recommendation of the P2 or N95 respirator, eye protection and gloves. And in many settings, according to local guidelines, it's gowns as well. There's a recognition that negative pressure rooms are not always the right place to do the resuscitation because they can be restrictive from a spatial point of view and may actually hinder resuscitation at times. So we've described that. The adaptations to airway interventions have been removed, and it's really a recommendation to adhere to the standard resuscitation protocols at this stage. And then with regard to the BLS, it's more a description that we don't actually refer to masks specifically about lowering the risk of acquiring COVID, because the mask recommendation is really a community recommendation on the basis of the likelihood of COVID being widely spread, etc.
Excellent. And I want to come to that basic life support BLS in just a minute. Simon, anything to add in terms of flagging any other changes in this most recent update?
I think what we've tried to do this time is really get back to basics and, is do what you would normally do and keep yourself nice is really the only message that we've got. Because all of the little things that we tried to, massage in around, whether you put a mask on the patient while you're doing CPR, or whether you cover this, or whether you clamp that, or whether you, have people here and there, it just made a relatively simple thing, which is give chest compressions, give rescue breaths, and defibrillate when you can, into something that was really complicated, and it just made it so much harder than it needed to be. I can see exactly why we did it at the time, but the key to good resuscitation is doing the basic things quickly and correctly. And if you do that, then people will survive. So just pairing it back to that and recognizing that we are able to keep ourselves nice through standard use of PPE and standard, community vaccination, as well as healthcare worker vaccination.
I do think that guidance, do what you usually do and keep yourself nice, could just be applied to everything, actually. That's a general life rule. As I'm out and about this summer as a non-clinician, if I'm in a situation where somebody needs me to be providing basic life support, what are the key messages for me, Simon? What do I do if I see somebody? And this is an area which is a bit different for us in Taskforce. We're rarely providing guidance for the public. We're often focusing on clinicians. But as a non-clinician, what's your advice to me in terms of providing basic life support in the community?
Well, I think in the community setting, you're either going to be doing what you would do in any other situation and keep yourself nice. And keeping yourself nice is, if you're prepared to give mouth to mouth, give mouth to mouth. And there are some people that are going to give mouth to mouth on anybody. And there's some people that, I'm not so sure about that person, but I would otherwise. But, compression only CPR is very a standard sort of mechanism. In kids, we're very reluctant for people just to do compression only CPR because they do need breathing and so on. But really, if you're trained in first aid, give first aid. If you're trained in CPR, do CPR. If you don't know what you're doing, call an ambulance and they'll talk you through it. The likelihood of someone with such severe COVID that they've, had a cardiac arrest in the community being the cause of that person dropping in front of you was pretty much zero. People are going to die from heart attacks. People are going to, fall in a pool and drown. They're going to do all the things that they've been doing pre and post COVID, and they're not necessarily going to have COVID. And you're going to be vaccinated. They're probably going to be vaccinated. So just get on and do what you would normally do.
I'll keep that in mind. Peter, any additional advice for me and others?
No, I think that's good advice. Certainly the main thing is that people should be empowered. They should feel comfortable that they can do exactly what they would want to do. And that is, to call for help. And as Simon said, if you don't know exactly what to do, then follow the instructions that the people at the end of the phone will give you. And if you do know what to do, then chest compressions, if you feel comfortable with adding mouth to chest compressions, then that's fantastic. And that's certainly what we would prefer, because we think the outcomes are better with that. But chest compressions and early access to a defibrillator will, double or triple the chance of the patient surviving. So yeah, it's really about empowering people to actually get on and do things.
I'll still be hoping that I'm not in that situation, but I do feel like I know what to do if I am. Thanks, guys. On every Taskforce TV episode, I close by asking one question, which is really, if you had a magic wand, if there was one thing that you could just change that would improve the conduct of CPR in context of COVID, or would improve the outcomes of CPR given the context of COVID, Peter, what would that one thing be? What would your magic wand get you?
I think try to ignore the COVID as much as possible and just do the things that you're trained to do. Because in the background, you're going to be doing the PPE and all that sort of thing that's required either by the community or the health service in which you work. But if you just do the other basic things, then you're likely to have the best possible outcomes.
Simon, one thing you'd change to improve the conduct or outcomes of CPR?
I think we've got a good program, across the state, across the country. The good SAM app and those sort of public access first aid things, the things that are there already work. And just, again, doing what you would normally do, doing what you're trained to do. And, we're a lot safer now than we were. So just keep doing what we're doing.
Thank you both so much. I feel like that's a really clear and reassuring message, and certainly been a helpful conversation for me. I also want to thank you both for your generous contributions across the Taskforce work over the last 3 years. We've all benefited as a result of your effort and expertise, so thank you. I hope those who are watching have enjoyed today's show. Please feel free to send in your questions if you'd like us to ask questions of experts like Peter and Simon or other colleagues in the task force. And do feel free to share this with your colleagues and friends, and look out for our next episode of Taskforce TV in 2023. Thank you all very much.